I'd like to welcome one of my colleagues who I work with very closely and a good friend, Professor David Lloyd. A little bit about him. I mean, his biography is so long that I could do a longer introduction than his talk, but I'll try and make it as succinct as I can. He qualified in 1980 at St. George's Hospital in London. He did a 5-year residency, surgical residency here in Leicester, and then went off to do a 3-year liver fellowship in Chicago. From 1990 to 1992, he ran the living-related liver transplant program in Hamburg in Germany, and then came back in 1994 to Leicester and was appointed as a consultant liver and laparoscopic surgeon here. He pioneered many laparoscopic procedures and was well known as quite a slick laparoscopic surgeon when I was a baby during my surgical residency. In 1997, he did the first laparoscopic liver resection in Europe. And in 1998, he developed the Lloyd release procedure, of which we'll hear about a lot today. He was involved in developing liver microwave ablation machines, and many of the radiofrequency or microwave ablation machines that we use as interventional radiologists today owe a lot to the technology that he helped develop all those years ago. Without much further ado, I'd like to welcome Professor David Lloyd to give us this talk, enlightening talk on the sportsman's groin and inguinal ligament. Thank you.
Well, Winston, thank you very much indeed. It's a pleasure to have that introduction. Thank you. And thank you, Hilary, for this invitation for me to talk on sportsman's groin. As Winston said, I have been interested in groin surgery for more than 20 years. So the aim of my talk today will be to give you a personal philosophy and my approach to groin pain, introduce the concept of inguinal ligament disruption, recommend releasing the ligament for the treatment of this specific pain, and discuss MRI imaging towards the end. So sportsman's groin is very common. Most athletes will strain a part of their groin in their career. Certainly 5% of athletes will in fact have some kind of surgery or treatment for a groin injury. And if you're involved in twisting or kicking sports, it's more like 10 or 13% of players will have some significant intervention for a groin injury. However, we have confusing terminology, and groin pain is grouped together as one type of diagnosis. So we have many eponyms, which leads to the confusion. All these mean the same thing, essentially. Groin strain, Gilmore's groin, adductor strain, groin rupture, sportsman's groin, sportsman's hernia, athletic pubalgia, inguinal pubalgia, osteitis pubis, pelvic pain syndrome, baseball hockey pitcher syndrome, that's got to be one of my favorites, and many more. I like to keep it simple. I'm a simple surgeon, and if we have a pain, we call it a pain of a certain atomic structure. So athletic pubalgia means pain around the pubis in a sportsman. Well, many sportsmen get other types of pain, and non-athletes get pubic pain. So I don't like that as a branching term, not for a clinician giving a specific diagnosis. Again, a sportsman's hernia, I've never liked this term. We all know that a hernia is a protrusion, and a protrusion of a viscus through an opening or potential opening. This is not a hernia in the groin. They may have slight weakness of the posterior wall within Hasselbalch's triangle, but this is not a hernia, and the term should be abandoned. And some of my colleagues also think that this bulge will press on the genital branch of the genitofemoral nerve and cause pain. Well, the genital branch just supplies the cremasteric muscle and part of the skin in the upper scrotum. It does not supply any part of deep groin pain. So dividing or treating the genital branch, in my experience, does not treat groin pain. Osteitis pubis, I do think this is overused, and there's no doubt that some patients have significant osteitis pubis, and some of my colleagues are now recommended it should only be used in patients with infection within the joint because it is an overarching type of diagnosis. And sportsman's groin, I think this is meaningless. It occurs in non-athletes and in women. So for this talk, if you forgive me, I'm going to get rid of the term sportsman's groin and replace it with inguinal ligament disruption. So if we talk about terminologies using anatomical phrases, if we have an adductor tail strain, let's use adductor tail strain. And interesting, the radiologists are the only group that use this precise terminology. And I do respect them for that, because they will call it what it is on the MR scan. And they don't call it an overarching term. They don't send a report back saying, yes, we think this patient has athletic pubalgia. They'll give me a specific term. So again, inguinal ligament pain or abnormality, obturatus externus, and I can go on. So I like these specific terms for pain. You don't go to a doctor with abdominal pain and he says you've got abdominal pain. He'll say you've got appendicitis, biliary colic, you've got diverticulitis. So we have to be specific about where the pain is. And there are many more examples, and etc. means etc. So the groin area can be confusing because it's this whole area between the thigh and the lower abdomen is known as the groin. And it's very complex. It's full of nerves, arteries, bones, joints, ligaments, and it's very difficult to hone in on exactly what does cause this pain. So for simplicity, let's divide the abdomen and the leg by the inguinal ligament, because most of my colleagues see inguinal ligament or abdominal problems, and orthopedic surgeons see adductor and hip problems. So if we take the torso, orthopedic surgeons operate on the hips and adductors usually, and therefore when we are suspecting these problems, those patients and sportsmen are sent to orthopedic surgeons. If it's abdomen, they come to the superheroes of surgery, which of course are general surgeons, and we operate on the abdominal wall and of course inguinal hernias and the inguinal region. We of course need Winston Rennie and his colleagues to help us with radiology, but I've carved out a slightly unique position in the middle where I operate on the abdomen and I also operate on adductor pathology and tissues around the pubic bone. But today I don't have enough time to discuss adductor strains, so I'm not going to discuss adductor pathology today. But the diagnosis of Sportsman's groin or inguinal ligament disruption can be confusing, as there is a balance between clinical findings and radiological findings. So I'm going to shed some light, if I can, by mentioning the inguinal ligament as they attach to the pubic tubercles. I'm grateful to Andrew Franklin Miller for his writings on the pubic clock, and this has helped me in my clinical examination because it allows me to go around examining the groin from the medial adductors, right lateral up to the inguinal ligament, and then around to the conjoint tendon and rectus muscle. And by doing that several times and comparing both groins, we can begin to pick up a clinical picture of exactly which anatomical structure has pathology and is causing the pain. So the mechanism of injury, of course, twisting, kicking, and repetitive movements are very important, but you can also get a single sudden jerk which causes an evulsion, and that sets up this burning ember of painful symptoms until it is treated. This is where England beat Germany. I think it was 5-1, but you just look at the mechanism of injury here. Football or soccer is a very dangerous game when it turns in terms of groin strains. So if you think about the mechanism and the stresses and strains, the lateral border of the rectus muscle meets the inguinal ligament. And I do a lot of sailing and windsurfing, and it did remind me of the lower part of a windsurfing sail. And I don't know whether any of you have tried windsurfing, but in a high wind, you let go of the boom and there's so much force, the sail and mast can be ripped out of your hands. So the lower part of the sail would be your inguinal ligament, and the mast itself here would be the rectus muscle. And this illustrates the amount of stress at the lower part as you get a rupture. So you can imagine the inguinal ligament joining the lateral border of the rectus muscle onto the pubic tubercle, and you'll get a rupture. And patients come to me, and most of my patients put their finger exactly there, above the pubic bone towards the right. And underneath that, we will have the inguinal ligament, lacunar ligament, and of course, pectineal ligament to pectineus, and the adductors, particularly adductor longus, is quite a long way away from that. And if patients present with adductor pain, they'll point underneath the groin and they'll grab and show me their adductor tendon. And I did think this might be similar to tennis elbow. So what about the inguinal ligament? It doesn't do very much. One would think it has a stabilizing function. It has no such thing. It does not stabilize the hip joint. In fact, it's not really anywhere near the hip joint. I would go further to say that the inguinal ligament is the lower border of the external oblique muscle, and it attaches to the pubic bone. And if a muscle attaches to a pubic bone, it should be called a tendon. So it's not really a ligament. I think it's been misnamed. It doesn't cross a joint. It doesn't have any stabilizing function. And I think it is in fact an inguinal tendon. But that's a fight for another day, and one that I'm never going to really win. So I perform laparoscopy, and this is very clear. You can perform a laparoscopy, put about 2 or 3 liters of gas inside the abdomen, peel down the peritoneum, and you can see the inguinal ligament from the inside. Now, the upper part here is the normal part of the inguinal ligament. It's white, flat, thin, and shiny. But you can see the lower fibers, about 40%, have been torn, and the lacunar ligament doesn't really exist. And there are a number of these. This is another patient, again, with left-sided. The pubic bone is here. The midline would be here. This is the inguinal ligament joining the pubic tubercle. Femoral canal here, pectineal ligament here. And this is torn. The lower half is torn. There's a thickened band here, and it's all looking a little bit abnormal and hemorrhagic. This is Paul Dickoff, who came to me 20 years after playing professional football in England, and I couldn't really make head or tails out of his inguinal ligament pathology. He had so much disruption, it was extremely confusing itself, but all that had to be taken down. This is another one where the inguinal ligament itself is completely wrecked and abnormal, a thickened band. There's a hole above the ligament. There's a hole in lacunar ligament. This is the pubic bone. This is the right side ligament coming on to the pubic bone itself. Again, this is another right-sided inguinal ligament. I go back there. A right-sided ligament. This is normal. There's a band here, and this 50% is attenuated and torn, again showing a repetitive strain injury and tearing of the ligament during this physical action. And I can show you many, many more, but you get the picture that the inguinal ligament is abnormal. Here there's a hole in the ligament. Here there's a band in the ligament, which is very painful. I've taken biopsies of these abnormal inguinal ligaments, and usually you'll see a linear architecture of the nuclei, the nuclei within the ligament. But these abnormal ligaments, the normal architecture is completely disrupted. You've lost the linear, the linear picture of the nucleoli and the nuclei, and you get this distorted, disrupted picture. Here we have edema within the ligament itself, and in severe cases you get edema and even hemorrhage. So these ligaments are certainly abnormal. So in '98, this chap, Ian Marshall, came to me. He had already 4 Gilmore operations by the great Mr. Gilmore, a great raconteur himself, but he failed to improve his symptoms. And he came to me asking me if I had any ideas. And at that time, I actually had tennis elbow. And I said, we can try and excise part of the inguinal ligament, because I believe you've got inguinal ligament pathology. And because it was his last year in his contract, he was 35, he said, yes, do what you want. And I said, well, just hope your leg doesn't fall off. So would an inguinal ligament help? So 23 days after I performed a laparoscopic release of his ligament, I'm sorry I don't have a video because it was a long time ago. This was him coming on in the second half and scoring a goal 23 days after my operation. So this gave some credence to the procedure and gave me some hope that maybe I'm onto a good thing with regard to treating groin pain. So this is what I do at laparoscopy. There's the thickened band, and the lower part of the inguinal ligament on the left side is attenuated and torn. underneath you might be able to see part of the lacunar ligament down here. This is external oblique going to the outside of the abdomen now. The spermatic cord structures will be in here, and I will perform a release of the ligament completely so it does not pull against the pubic tubercle anymore. I then reinforce the whole area with a soft mesh, and then that is then covered by the peritoneum. And that mesh acts, it takes the pressure off the inguinal ligament, and that ligament just scars over and lengthens the ligament over a few months until it repairs. I often see this. These are patients who've had open groin surgery for groin pain. And there's this philosophy that some patients and some players would benefit from having their posterior wall reinforced by proline sutures. My problem is that I see many of these players come to me when they have not had any benefit from this procedure. So I do take some time in removing all of those stitches. We might get back into the abdomen. I think there's a second part, just cleaning it. So, and I will then remove all these stitches, and you can see a lot of abnormal tissue here, thickening. There's no lovely, pure white inguinal ligament at all. Again, this is the left side. This is the pubic bone. And I did this operation 2 weeks ago on a professional football player who's been out of action for 6 months because of his injury and this operation. And I saw him this morning, and he's now back training, and he's hoping to renew his contract. So he's very pleased. So all those sutures I removed and I gave to young Jamie as a present. So this would be another Polish player. This is now 14 days after surgery. And you can see that, maybe you can't see, but they're just little scars. And this is him playing at 14 days after my operation. They mentioned this operation 2 weeks ago today. And I was surprised myself that he played the afternoon that I saw him. I reviewed him in the morning and he played in the afternoon. This is Shane Williams, a very famous Welsh rugby player.
There will be many Welsh people around the world who have never ever seen a situation like this.
And that was about 3 weeks after surgery. And again, not to be outdone, I do help my Irish colleagues. And this is Owen Reddin. And that was about 6 weeks after surgery. Now, this chap has become quite famous in the UK. Certainly in 2016, he's an international soccer player, plays for Leicester City. And he had groin strain in the latter part of 2015 and the early part of 2016. And it was the year that they wanted to try and win the Premier League, this very esteemed cup in English football. So he had a release in January 2016. And he always plays at the front, so he'll be down here somewhere. You see, that does annoy me. It's not minor at all. He's had amazing surgery. And here he goes on to win the cup. And I hope that I had something to play in Leicester, our local team, gaining the Premiership title in 2016. Recently, he suffered another injury, and this time it was above the pubic tubercle and it was in his external oblique. And I couldn't get a photograph, but he had quite a long 8-centimeter tear in his external oblique, which I repaired and reconstructed. And again, this is now 2 weeks after surgery, and he's playing once again. And I like the fact that he plays the guitar at the very end, or that's not showing. But it just demonstrates that if you do precise surgery, you can get players back relatively quickly. I put Catherine up to demonstrate that it's not just athletes. Catherine slipped in Debenhams, which is a superstore in the UK, on a marble floor, damaged her groin, and for 2 years she was on crutches, then was confined to a wheelchair and was thrown out of a university in Warwick because she couldn't go and attend all the lessons. And in those days, we didn't have Zoom. So I performed a release on her, and Mr. Patel, an orthopedic surgeon in London, wrote to me and said, I just wanted to drop a line and thank you for a very successful intervention for Catherine. I reviewed her in my clinic today and found to my surprise that she was walking out of a wheelchair and markedly better. Similarly, Emily here was a ballet dancer and again suffered a groin injury and remained on crutches for about 2 years and had seen quite a number of specialists. Once again, I performed a release. She also had meralgia paresthetica, so I released her lateral cutaneous nerve of thigh, which is an operation we've also written up. And she wrote back to me a month later saying, thank you, Professor Lloyd. 1 month after my operation, I feel I've now got my life back. Emily. This chap came to me from Afghanistan with severe groin pain. He had to end his tour of duty. And he came to me saying, I've got this thickened band in my groin. It's so painful. I just want myself or one of my mates to cut the band. Can you do anything? And that's a picture of his band, very thickened band. And when I divided it, you can almost hear a ping as the ligament came away from the pubic bone. And again, he wrote to me, it's 4 weeks after my operation, and I'm now training with a 40K backpack in Norway. Thank you so much. We've published our results early on, and we have done quite a number of athletes and Olympians. We significantly improved their function at 1 month. And this is players who are unable to train or play to become fully fit at 1 month. We looked at their symptom severity score before the operation. They had very high scores of pain, limiting their activity, and a month after surgery, significant improvement. And again, the frequency of their symptoms, and that would include coughing and sneezing, getting out of bed. These are all dramatically improved following a release procedure. I've done some England rugby players. This is about 5 years, and we've contacted them all, and they've not had a recurrence of their pain. 10 years, these football players and a rugby player, again, still doing well without a recurrence of their pain. So now we come to perhaps a controversial part of the talk, imaging. Well, ultrasound, this is from Winston Rennie, can pick up the inguinal ligament as it fans out onto the pubic bone. And if you look, this is a very healthy, young, fit, normal inguinal ligament. And the more observant of you would notice that the patient is no other than myself. So I thank Dr. Rennie for finding something normal in my aging body. But this patient, this will be the inguinal ligament in this position here, joining onto the pubic bone. And this is very thickened, abnormal, with some tears and artifacts within it. And this would represent an abnormal ultrasound appearance of an inguinal ligament, although it's not always reproducible. Now, on the MRIs, there have been many reports and reviews on MRIs. Fon and Spence have said, well, routine MRI is not justified for Sportsman's groin. Deason and Pappas have also said the definition of a sportsman's hernia and athletic pubalgia is controversial. Some people don't even believe it exists. Morales Conde, a colleague of mine, says it's very controversial and difficult to define. Silvers has said there's no correlation of MRI findings in hockey players when they have groin strain. Moreover, he said that 77% of asymptomatic hockey players will have abnormal findings on an MR, which of course don't correlate to their symptoms because they don't have any. Although I do think, to be fair, these are slightly older reviews and we are getting a lot better at looking at these the findings on MR. Litwin and colleagues have said that athletic pubalgia is confusing and therefore we shouldn't even pursue looking at it even further. So here you can see a lovely MRI scan of rectus muscles, the pubic bone, the conjoint tendon, the spermatic cord, inguinal ligament, and here you see a hematoma and edema within the rectus muscle itself. Over here you see a post-operative picture of one of my releases. These are the pins. We connect the mesh to the pubic pectineal bone, and you can even see a part of the mesh on the scan, which looks nice and flat and healthy. Again, these are pictures showing adductor strains and tears. This patient is a patient of mine. He plays rugby, and every 3 months he comes in with a different injury, but they're usually around the adductor muscles. This patient has an inguinal hernia, and on this view you see the inguinal ligament and the hernia going down to the right hemiscrotum. This would be a labral tear. Doing an MRI arthrogram here. Again, confusing, but this man actually had an abscess in his inguinal canal here with a surrounding edema. So this is good to exclude significant other injuries. This would be a standard adductor longus tear, but mostly I see some edema in the bone. This patient has ruptured his myotendous junction in the right adductor. This patient will have inflammation around, or has inflammation around the obturator externus muscle. This patient of mine presented with left-sided lower abdominal and groin pain, but did have a paralabral cyst on the right. And when we looked at it further, this is a Dixon sequence showing acetabular edema, again with a paralabral cyst. But when we did this image, Dr. Rennie here picked up here edema, again on the Dixon sequence within the left pubic bone, which that did fit with his symptoms. And he went on and had a left release, was fine, back playing football, and we did nothing so far to his right side. So as I've mentioned, these are the normal findings in patients with inguinal ligament disruption. They will have bone edema as an indirect sign that there's something going on with tension and inflammation in the pubic bone. Again, tension in the left pubic bone here and in both sides here. Again, slightly more on the superior surface than the inferior surface, indicating the stress is more due to the inguinal ligament as opposed to the adductor. Again, other views of the stresses and strains you see in the pubic bones, and this one in particular, very subtle edema at the superior aspect of the pubic tubercles, indicating inguinal ligament pathology as opposed to adductor pathology. So in summary, I'm hoping to have shed some light on the clinical aspects of groin pain, proven that we have pathology in the inguinal ligament in some patients, demonstrated that releasing the inguinal ligament is beneficial in many patients, and the MRI is excellent for most groin and abdominal pathology and excellent in excluding other pathologies. And of course, it's also very good for assessing pubic bone edema. So in final conclusion, the inguinal ligament release procedure offers a potentially curative treatment for patients and athletes with severe groin pain. So finally, I want to thank you, Hilary, for inviting me to give this lecture. I'd certainly want to thank Dr. Winston Rennie for his very kind introduction and his expertise and support over the last 10 or 15 years. I could not have done what I've done without him. So a great thank you to him, and thank everybody else for listening. Thank you.
Professor Lloyd, that was really fantastic. You've really given me a different perspective on what exactly is going on here. I don't think I understood the scope of the pathology in these injuries. So just to be clear, that thickened cord is the ligament, the inguinal ligament itself? Is it just hypertrophied and scarred, or?
Yeah, so on the pictures I showed you, I think what happens is you get tearing of the ligament, usually the under surface, the inferior aspect of the inguinal ligament, and then the rest of the ligament tries to maintain the strength and the tension by hypertrophying its own fibers. So you get these thickened bands building up in over maybe a year or 2 years in these athletes with who continue to play their sport and have a repetitive strain injury to their ligament.
So this is, I mean, it seems that there's a spectrum of injury, and it can be isolated to this whole ligament, inguinal ligament complex, but you can have, you know, associated tearing of the adductor and the
Yes.
rectus,
So there's no doubt that
aponeurosis. So when you see the more extensive injury, do you go ahead and repair the aponeurosis and the adductor as well?
Yes, we would repair the injury in open surgery, because it's not just laparoscopic surgery. If it's a lingual ligament, I will try and do that. But many patients have already had a laparoscopic mesh repair for groin strain. And they come to me already having had, and if I know the laparoscopic surgeon, I know that he's placed the mesh in the right place, I'm then confident of doing an open release through a small incision. And also, if it's adductor, the most common adductor procedure I perform is a very limited tenotomy, and that seems to work. But we operate on very few adductors. I leave that mainly to the physiotherapists and the sports doctors, because a lot of them can improve with physiotherapy. But when it gets on to 3 months, 6 months, some players have been out for a year with physiotherapy. The players and the managers themselves are saying, "Come on, we can't just keep on doing conservative treatment. You have to have some kind of surgical intervention." So there is a lot of pressure as well. But there is all these tissues fuse over the front of the pubic bone, and that's why it's confusing. The rectus sheath, conjoint tendon, inguinal ligament, adductors, they all come and form an aponeurosis on the front of the bone. But I think the majority you can separate either above the ligament, together with the ligament, or adductors. And about 10%, there's this significant crossover, and they're a difficult group to try and treat.
Do you have experience with ultrasound evaluation of this pathology? Do you prefer, or I mean, is there a reason you might order ultrasound rather than MRI? Or
well, a lot of patients have had an ultrasound, and they have this posterior wall weakness. And we looked at a number of our medical students and performed an ultrasound scan many years ago, and a lot of them will have a posterior wall weakness.
Insufficiency, right?
And I'm not sure whether that is pathological. It's not a hernia, because you're not herniating something through it. So certainly in a slim patient with somebody like Dr. Rennie, who knows what he's doing, and on a good day with a following wind, you can pick up abnormalities by ultrasound in the inguinal ligament. But we do tend to rely most of the time on indirect signs, such as the pubic edema on MRI scans.
Yeah, I mean, I've never used it. I've never used it for this diagnosis. I wonder what I'm missing on the ultrasound. We evaluate.
Well, maybe you can, if you find some abnormalities, you can send me some pictures now that you know what you might be looking for.
Sure thing. No questions. You're getting a lot of high praise and appreciation in the chat box. Excellent lecture, great lecture, sir. Very enlightening. Okay, Dr. Alizai is asking, in your opinion, is there any role for image guiding percutaneous interventions in these patients?
Yes, is the answer. There was a vogue, and there still is a vogue, for patients who have the pubic cleft signs, and we suspect adductor pathology or osteitis pubis. It's a terminology I don't like to use very much. Often my players would have already had a pubic cleft injection with or without some success. And sometimes it is successful. So it might be worth trying to avoid an invasive operation. And all operations will have a complication rate and a failure rate. So yes, whether you can, I don't think you should use radio frequency to ablate the inguinal ligament. My concern is that it would weaken the ligament and you then get a rupture. So then you've got pain, a rupture, and a possible hernia formation. I would be reluctant to use that, despite the fact I've developed a microwave machine myself, which is now being used by angiodynamics. I would not want to put my microwave probe into a delicate tissue like that when there's something a bit more predictable that we can do. But often the patients will have injections of local anesthetic and a cortisone injection into various areas. And that, indeed, I would agree that it's a good testing diagnostic tool. And certain players will need one injection and they get better. So that's great. You can avoid an operation.
So is there any sort of post-operative physical therapy that?
So it's very, if my theory is correct, that you get a repetitive strain injury of the inguinal ligament, which then causes inflammation, scarring, shortening, even by just a few millimeters, this is what stops these players from being able to open up and kick. So this is why I don't like the philosophy of adding more sutures to tighten up the ligament even more. So I release the ligament, release the tension. So the post-operative rehabilitation is quite aggressive. They must do a lot of stretching. As soon as they're comfortable after 2 days, they get on a static bike. By the end of a week, I want them on a treadmill, and I want them in a swimming pool if they can't weight bear, because it might be painful. And certainly by 2 weeks, I want them to consider light training. And I always tell them that my aim would be to get them back training, at least, maybe not playing a full game, but training at 4 weeks with a view to playing at 6 weeks. The superb athletes have demonstrated today they're unique and they're freaks of nature. They can get back after 8 days. Even my goalie here in Leicester was back after a bilateral release after 5 days, because he was determined to play for his country, Denmark, after the operation. But yes, they have to wear compression shorts. They must ice every day to stop swelling. They must do exercise to keep the inguinal ligament away from the pubic tubercle, and a lot of stretching, morning, noon, and night, to get over.
So is there any possibility that you could avoid the injury with like prehabilitation? You know, like in the shoulder, the patients get the internal rotation deficit and they have stretching exercises.
Yes.
Is there something you might imagine might avoid this?
We've not looked into that, but these players come with an established injury. So what we're saying is they should really perhaps do a lot more, not just stretching, but building up to kicking a football 50 meters. They should kick it 10 meters 20 times, and then 20 meters 20 times, but they can't do that. It's impractical to do that before every game of football or American football. You can't spend an hour doing prehabilitation as you get onto the pitch. So I think it would work, but I think it's impractical.
I see.
So I would like to say thank you to David Lloyd, Professor Lloyd, for such an excellent talk and enlightening everyone all across the world. I mean, I noticed there were attendees from nearly every continent on the planet. So OCAD is a great forum, and it's fantastic having surgeons come and talk to us about their clinical experiences. I've learned so much from him over the years about pathology that I didn't even know exist. And working together with good people is what life is all about. And with that, I thank you and thank everybody for attending, and thank you, David, again for an excellent talk.
It's been a pleasure. Thank you very much.